So I'm a Spelman alumna and also a Howard Law alum. So I'm really excited to be here, especially on campus. So today's session is Close the Healthcare Gap by Unlocking the Power of Data to Advance Collection and Analysis. So we have 4 great presentations. I'll just give the title and then I'm sure our presenters will give a little quick bio and spill. So we have Advancing Health Equity in Data Collection and Analysis. We have Practical Approaches to Increase Organizational Capacity to Collect Data, Standardized Demographic Data within Complex Healthcare Environments. We have Unlocking the Power of Data, a comprehensive approach to improving health literacy in the dialysis practice setting. And then lastly, we'll have Closing the Care Gap, a multifaceted approach for diverse Medicare Advantage populations. So we'll bring up our first presenters in Advancing Health Equity in Data Collection and Analysis.
All right. All right. Hi, everyone. My name is Brittany McGill. I am a senior social science analyst in the Office of the Assistant Secretary for Planning and Evaluation, or ASPE, as we affectionately know it, at HHS. So I'm really excited to be here with you all today and be here with my co-presenter, Amos from Mathematica, to share with you all some tools that we have developed for advancing equity in data collection and analysis. All right, so just to give a very quick background, these tools were developed by the HHS Equity Technical Assistance Center. This is an internally facing TA center that is looking to help build our internal capacity as HHS staff to center equity in our work. So center equity in our research, our grant making, our policy making, and just generally really try to operationalize our commitment to equity. Okay, we're committed to equity, but what does that mean? How do we do our day-to-day jobs differently to really advance equity? So you can see several of the work streams here for ETAC. So Mathematica has been the contractor for this work, and all of this work has been conducted collaboratively with experts with lived experience in HHS programs in a wide array of areas. So just one of those work streams has been to develop some resources to help us in our day-to-day jobs as HHS staff. So you can see a range of tools shown here. So all of these tools, again, since this was an internally facing TA center, they're really specific to HHS staff, but we wanted a lot more people to be able to benefit from them. So we did adapt several of those tools for a broader, more public audience. So you can see all of those tools and topics here. These are all available on ASPE's public website. So we are going to be sharing just 2 of those today. So Lauren is going to tell you more about our guide for centering equity in quantitative analysis. So, a lot of times when we're working with quantitative data, we didn't design or collect the data. So, what can we do to really advance equity? And then also thinking about intersectionality. What does it mean to incorporate intersectionality into our research? All right, I'm going to pass it to you.
Great, good morning. I'm Amos, a senior researcher and deputy area director for state and local human services with Mathematica. I direct the Equity Technical Assistance team, and I'm really excited to highlight some of the work we've been doing in collaboration with Brittany and her HHS colleagues. So the tools that I'm going to discuss today were developed with the HHS evaluation policy in mind. HHS recognizes evaluation as an essential process towards achieving its mission to enhance and protect the health and well-being of all Americans, and is committed to building evaluation capacity and maintaining high-quality evaluation practices. The first tool, our guide on advancing equity through quantitative analysis, was designed to meet 2 objectives: to help both data specialists and what I call the data curious identify common biases that can adversely influence their research and analysis, and secondly, to explore specific quantitative methods and tools to help mitigate these biases. To meet these objectives, the tool details 4 stages or steps in the research process during which various methods and strategies could be employed to advance equity. The first step being planning and design quantitative analyses with an equity lens and focus. Secondly, to identify and compare subgroups. Third, to assess and address data quality and small sample sizes. And fourth, modeling subgroup and distributional differences and regression equations. The methods and strategies recommended in the tool are responsive to a number of guiding principles. For example, one of the tool's underlying assumption is that although our goal is to conduct objective research, we must recognize that we're wonderfully imperfect as human beings, and therefore the analyses and research that we produce will be subjective. So some of the other process that this tool, some of the other principles that shape this tool include the importance of engaging individuals with lived experience as a core component of equitable evaluation and research, and the recognition that first, policy impacts can vary across subgroups and communities, and that those impacts can be disproportionate, that imputing misreported or missing data can introduce bias, and comparing subgroups can reveal advantages and disadvantages. That said, our choice of reference groups and measures can introduce bias and therefore misleading or potentially harmful results. Our second tool, a guide on advancing equity by incorporating intersectionality in research and analysis, outlines 4 key steps and associated strategies. Firstly, planning research with an intersectional framework, incorporating intersectionality in quantitative analysis. Third, examining intersectionality using qualitative data. And fourth, understanding the strengths of a mixed methods approach. On this slide, I've included 2 images illustrating the concept of intersectionality. You'll see this graphic in many of our resources. On the left, several lines representing different dimensions of a person's identity, such as faith, their language, their geographic location, disability, race, ethnicity. They all cross in the middle at a point labeled intersectionality. On the right, icons of 2 people are each labeled with different identities, showing how they have some similarities. For instance, these 2 individuals are both queer, but that other aspects of their identity, such as one is Latino and the other is Black from a rural community. These identities also cross in the middle point labeled identities. As with the first tool, the methods and strategies that we recommend are responsive to a number of guiding principles and common questions. For example, groups and individuals within them are not homogeneous and face different barriers. Since our analytic capacity and resources are not limitless, how might we determine which intersecting identities to examine? How do we select among the many ways to calculate and report disparate outcomes across groups with different intersecting identities? And we also promote the use of qualitative data to examine intersectionality, because it can shed lights on experiences, barriers, and strengths for people with different intersecting identities in ways that quantitative analyses cannot do. For example, here's an example I should share of a strategy that we suggest to calculate and report disparate outcomes across groups with different intersecting identities. When sharing a strategy such as this in our tool, we present both the advantages and disadvantages one should consider before employing the strategy. I don't know how many of you are data nerds, so I won't go into those, but I just wanted to highlight some of the example tools or strategies that we present. This is a risk ratio. It can be used to assess the likelihood of an outcome across groups with varying intersecting identities by comparing outcomes for 2 different groups. In this instance, we can use the risk ratio to calculate the relative risk of COVID-19 infection between Mexican Americans and Black adults with developmental disabilities. We can do so by comparing the percentage of individuals within each group that have been infected. For this example, Mexican American adults are the focal group and so are represented as the denominator in the calculation. Black adults are the reference or comparison group and so are represented as the denominator. If you're not familiar with how to interpret risk ratios, when you're calculating them, if the resulting calculation is 1, that means there's no difference between the 2 groups. If the risk ratio is greater than 1, it means the risk for COVID-19 infection in this example is greater for Mexican American adults than it is for Black Americans. When the risk ratio is less than 1, it means that the risk for COVID-19 infection is lower for the focal group. Please visit the HHS website to download copies of these resources. They are publicly available. And also, please feel free to reach out to Brittany or me with any questions about these tools. If you're HHS staff, I also encourage you, you're welcome to reach out to the center directly by sending an email to equity.ta@hhs.gov. Thank you.
Good morning, everyone. Nice to see you today. The name of our presentation is Practical Approaches to Increase Organizational Capacity to Collect Standardized Demographic Data with Complex Healthcare Environments, within complex healthcare environments. My name is Lisa Sloane. I'm the founder and CEO of More Inclusive Healthcare. We center our attention on training and education to assist health systems in data collection among their registration staff with respect to real data, SOGI data, and also we go into implicit bias education for providers.
And I'm Adrienne Gerlach. I'm the Vice President of Quality and Safety at South Shore Health. We're an independent health system located just outside of Boston, and I'll tell you more about our organization in just a minute.
So, having a little bit of nerves, but I'll bring it down a bit. So starting with health, with race, ethnicity, and language, we're going to go into 3 core best practices. So there was a lot of stuff that we could talk about, but we really wanted to hone in on 3 areas. So first is the utility of the Office of Management and Budget's 2+5. So that is like the core of all of our work. And so we're going to emphasize that. And then training registration staff in race and ethnicity data collection. So that also is a core component of collecting accurate data. So we're going to talk about that and some of the best practices associated with real data collection. And then also you've heard from others that don't let perfection be the enemy of getting started. So we're going to dive into that a bit as well.
So we're going to talk about these 3 core best practices in the context of my organization, South Shore Health's journey to advanced health equity. We're newbies in this space. I'm going to ask how many people are from health systems, hospitals, primary care practices. Okay, we have a few. So if you're new in your journey, hopefully some of this will resonate with you. So like I said, South Shore Health, we're an independent, charitable, non-for-profit health system. We're located just outside of Boston. We also have an integrated delivery network that's made up of over 1,000 providers, 75 different practices, a bunch of people on a bunch of different EMRs with different capabilities, over 15 plus EMRs or instances of EMRs. And like many of you out there, although we're small, our organization is complex. We were lucky enough to be a recipient of a grant award recently from the Institute of Healthcare Improvement and Blue Cross Blue Shield, and that's really helped us get started on our health equity journey and advance our efforts in real data collection. And as part of that journey, we participate in an equity action community that's run by IHI and Blue Cross Blue Shield. And we're learning about practices that we're going to talk to you about today. And that's how I've come to know Lisa and More Inclusive Healthcare and how our organizations have been collaborating together. So first, our first core best practice.
So on the screen, you see the OMB 2+5. So we've coined this phrase because we want everyone to remember that the OMB standards include 2 categories under ethnicity and 5 categories under race. These are the core categories that everyone should be starting with. So we know that there is a temptation to build in additional categories, such as granular categories under ethnicity. So for example, you might be looking at adding categories like Mexican or Puerto Rican, and that's all great if that's something that's needed in your region. However, don't forget to include those core categories of Hispanic, not Hispanic, or excuse me, Hispanic, Latino, and not Hispanic or Latino, because for data exchange purposes, we have to have those core categories. So keep in mind that the core categories are the parent categories. And in any data exchange an effort to have a standard, we all want to start with the parent category. So one of the things that we are seeing is that organizations will adopt the categories that they find online. So they might go to a performance quality reporting program and see granular categories, which don't include the minimums and that those parent categories, and they'll adopt those subcategories and not have the parent categories. And so then when there is a goal to exchange data or aggregate data within your system, which might have multiple EMRs, then there's a big challenge with the aggregation of that data. And we're all putting in this effort so that we can utilize this data to improve healthcare outcomes. Not utilizing the 2+5 is a setback. So that's why we want to put a lot of emphasis on utilizing the OMB 2+5.
So we'll give you a couple of examples from South Shore Health and our integrated delivery network about our process to implement the 2+5 standards. As Lisa said, at the heart of it, we're an integrated delivery network. We need to be able to exchange data, understand our patient population, and really be responsible for the population that we're serving. So at South Shore Health, we're an Epic shop, and we have the ability to update our EMR. So last year, we were not using the 2+5 standards. We had a category called race, another called Hispanic indicator that had 6 different options, and another one called ethnicity that had 125 different options. So we moved to the 2+5 standard in November, and that's really helped us streamline things. But the one thing we were really struggling with was, how do we capture granular level data? We want to be able to have that option. And if our patients share that information, we want to be able to capture it. So we were using race, ethnicity, but then we said, what should we be calling this other category? And people on our health equity team were saying, what about ethnic group? What about nationality? I'm not going to say the agency, but I went to an outside regulatory agency asking for advice. And they said, how about granular level data? I was like, do you want me to ask my patients, what's your granular level data? How do you identify with your granular level data? So ultimately, we worked with More Inclusive Healthcare, and they helped us do a best practice review. And we came up with the term heritage. Is it perfect? Probably not, but at least we can ask our patients, what is your heritage, or where is your family originally from? And through this process, we've been able to have a lot easier time starting to look at our quality measures. So we're starting to break down our hypertension rates, A1C, C-sections, things like that. And when we start with this high level and be able to dig in, it's a lot easier to identify health disparities. Lisa's going to talk about the experience of Sturdy Memorial, another large practice, and then a couple of our community providers that are 1-2 doc shops and their experiences.
So Adrienne and her organization are really dealing with some complexities in terms of EMRs. So her organization, the parent organization, has one EMR, and everything that she talked about is what they adopted. But they have 2 other large entities. One is Sturdy and one is IDN. And each of those organizations have their own EMR. So under Sturdy, they have a community EMR, so they don't have control over their categories. And at the IDN, these are all independent practices. They all have their own EMRs. So it's, it's a little bit crazy trying to get, it's like herding cats, literally, to get everyone on the same page. So with Sturdy, we actually had to do a workaround for them to be able to adhere to the 2+5. So the categories that they had were primarily granular categories. I'll just give you one example. Rather than having a category called Asian, they had other Asian. And then they had several other categories that would fall under that minimum category of Asian. So one of the goals is for them to be able to aggregate their data with the South Shore parent organization. And so they needed to create a workaround. So they trained their staff to collect the data utilizing a proxy for the minimum categories. So in this case, in the example that I gave you, when a patient is registered and their category is Asian, they would mark them other Asian in the EMR. And then they were able to roll that data up with their with the South Shore parent organization. With the independent practices, it was even more challenging because not only do they all have independent EMRs, but they also, the organization doesn't have control to mandate or dictate what those EMRs would consist of in terms of categories. So they established a set of best practices to share with the IDN and to say, hey, these are the goals that we have. This is the direction that we want to head in. We're going to provide your staff with training and education to teach them how to collect the data. And we want you to move toward the OMB 2+5 if you don't have that, and then other best practices. And we're going to talk about some of those other best practices later. So those were the workarounds that we used. And Adrienne's going to talk to the next slide.
We're going to talk about training. So I think you're up for this one.
Oh, you want me to go?
Yeah.
Okay. Okay. So, so we're going to talk about some of the best practices with regard to training and education. And we're going to slide through these pretty quickly, but if anyone wants to talk about them after the session, please feel free to chat with Adrienne and I. So first up is teach staff why we collect race and ethnicity data. So help them to understand that we don't collect race and ethnicity data to make individual clinical decisions for patients. We collect the data to help us with our population health management, our quality health management, to identify health disparities populations, and to aggregate and disaggregate data so we understand where health disparities exist in our system. So we definitely want to explain that why. Teach registration staff and managers how to respond to difficult questions. So we teach how to handle difficult questions such as, do you share this information with ICE or some other reporting entity? So we need to help patients understand that their health data is protected and exactly how that data will be utilized. Also, these days we are seeing people in the field being, registration staff are sometimes afraid to ask the questions. Depending on the region where you're in, it can be more difficult than in some regions. So we want staff to feel both comfortable and confident collecting the data, but also we want them to know that they are supported in their collection of the data. So you might want to implement a campaign like the Robert Wood Johnson Foundation developed the We Ask Because We Care campaign. Those resources are still available online. They're free of charge. You initiate the campaign, you have posters around the around your health center, and it helps patients to know when they're coming in that we're going to ask these questions about race and ethnicity because we care. So that really helps staff to feel more comfortable. Capture language, ethnicity, and then race. So the order matters. Asking language first is just good common sense. So it's also accrediting bodies recommendation that language be the first question you ask a patient when they come in. Then we recommend ethnicity next. So why ethnicity before race? Because there is research and evidence that shows that when individuals identifying as Latino or Hispanic are asked that question first, they're more likely to answer the race question. So you will end up having better data outcomes if you ask ethnicity before race, if you're able to. Provide definitions for categories. So this is a super important best practice, especially when it comes to the category of other. So one of the things that we saw with COVID, if you would go online to your state, you would see large chunks of patients listed as other. And so we didn't know how to deploy resources to specific communities. So that's why it's really important to, when possible, get it right and define other for staff so they know when to use that category. So it doesn't just become a catch-all, or when they, for whatever reason, don't want to ask the question or whatever, don't just drop an assignment into other. Be intentional about frequency. So frequency is validation. So if you ask the patient every time they come in, Every time you ask, you're validating the data. And data validation is super important for our quality improvement folks and our population health teams. So we want to make sure we're validating. Encourage patient self-reporting on the EMR portals. So we're seeing a trend toward asking race and ethnicity on portals, and lots of organizations are finding success with that.
And at our organization, we've tried to be really thoughtful and strategic about rolling out education to staff. So we've done online modules for all of our registration staff that are mandatory. And then for our managers, having them take that same training, and then also a virtual instructor-led training through more inclusive healthcare, so that they have better tools to be able to support their staff if complex issues come up with patients. So we're in the process of rolling that out now. And so our last best practice is really about being thoughtful about your approach to segmenting your quality data, like we've talked about, but also don't let that stop you from getting started. And so at our organization, like I said, we're new on this journey. We've had a lot of questions, many questions that we've come to Lisa and others within the equity action community about. So we thought we'd highlight just two, and you all must be data geeks or else you'd be at the diabetes session. So you'll probably like these. So I'm going to do a little bit of an ask the expert with Lisa being the expert. So the first question we had was, when we're looking at our race and ethnicity data, and we have data from multiple sources, the EMR says the patient's race is one thing, and then a payer supplied piece of data comes in that says the race is something else. What do we do with that when we're looking at our quality measures?
So love the question. I love these more detailed questions because it really represents an advancement in the work that we're doing. I've been pushing this boulder for data collection uphill for about 10 years. And, it's nice to see so many organizations that are now engaged in data collection and are getting down to the nitty gritty and asking these more nuanced questions. So what do you do if you have multiple data sources? How do you select the category or the assignments that you're going to accept for your patients? So create standards for the data collection, the data that you will utilize. Look to your organizations. You're going to have to do a little bit of investigating. So say you are looking at health plan data. First question is, are they utilizing the OMB 2+5? And if they aren't, then that should knock them out of the running. The second question is, are they doing patient self-reporting? So if you're doing patient self-reporting, that's the gold standard. That's the best data we can get. If they're not doing patient self-reporting, that should knock them out. And then finally, you also want to determine how are they validating their data? Are they asking the question once a year, once a quarter, every time the patient is engaged? If if your organization is validating every time or once a quarter, then you want to make sure that the data you're accepting from another organization is being validated at least as much as yours or more. Otherwise, it doesn't make sense to accept their data. So, at where we are right now as an industry, that's probably going to knock out a lot of your accepting data from other organizations. Healthcare providers are going to be the best sources for real data.
We're bumping up to the end of our time, so we'll save the second question. And if any of you all have questions at the end, we're happy to stick around. But I'll just leave you with this. As a newbie on this journey, I would say a couple things. Just accept the fact that there's not standards for everything. I think we've heard that over the course of the last 2 days. Sometimes there's a standard, sometimes there's not. Sometimes they conflict, but don't let that stop you from digging into your data and start segmenting your quality measures and see if you find a disparity. Does one exist? And trust that you know your patient population. These are your patients. This is your community. So feel comfortable in that and take action. And then I would just say, approach this work like you would any other process improvement, quality improvement project. Use your PDSA cycle when you're thinking about collection of real data, segmenting your quality measures, and ultimately trying to identify disparities. Thank you for having us. We appreciate the opportunity.
Thank you.
So we are feeling the pressure of time because I think we were supposed to be done at 10:45 or 11:45. She's gonna let us know though. So we're gonna pause and say, hi, Dr. Amber Paulus from Virginia Commonwealth University, and I am joined by Andrea Moore from Quality Insights. I'm a registered nurse. She's a licensed social worker. And we've been on this journey of leveraging publicly available data to give us more granular context for the patients that we serve in the end-stage renal disease world who are currently receiving dialysis across most states in the East Coast. So let's dive in. All right, so we just wanted to start off by what we're harping on here within the equity priorities for reducing disparities in health. So the first is around collection and reporting of analysis. The challenges that our colleagues just presented to you are not as prevalent in our space because we have a registry that allows us to capture data on our patients that is federally mandated, and we have some validity issues, but at least we have something to work on and make better. And then the fourth point there around advancing health literacy, and Andrea is going to give you the granular details on that. So we use the area deprivation index, although while being here, I will say we've looked at ways to level this up based on some other data resources that have been presented. And you probably all are very familiar with social determinants of health, so we won't jump in with that. So this is the process that we used. We are contractors to CMS as ESRD networks, and we get data from outpatient dialysis facilities. Our registry is run through what is now called EQRS. It used to be, its predecessor was Crown Web. If you work in a hospital environment, you have a similar product that captures data. We have a different contractor that takes that data from EQRS and transforms it into something that we can actually use based on strategic priorities that we have in our ESRD network contracts, and also gives us admission data that allows us to learn a bit more about our patient population. So our company and our data science department pulled that data and ADI data, the area deprivation index produced by the University of Wisconsin at the zip code level, because we have zip code data for our patients based on their addresses in the registry, and we were able to match those data sets because we do not capture social determinants of health in our registry. It's not quite capable of that yet. We have a long list of things we want to do to make it better, but this allows us to structuralize social determinant of health or vulnerability that exists in our patient population without at a macro level, which is what we work at, being able to ask every single patient what their needs might be. All right, so then we were able to flag patients at a certain threshold. So ADI runs on a scale of 0 to 100 if you're looking at the national interpretation, and we created cut points. We have 3 networks, so network 3, 4, and 5. I won't run down all the states, but just know we go as far as Puerto Rico and as far up as New Jersey, as far down as Virginia. We also have the lovely district of Washington, D.C. But our cut points were 97, 95, and 87. If you just look at those 3 numbers, you can see that there's a lot of vulnerability in the dialysis population. Now, looking more granularly, we looked at the rate of deprivation. So this is like all those states that are in that region. So network 3 would include Puerto Rico, network 4 would include Delaware, Pennsylvania, and network 5 would include West Virginia. I'm giving you the highlights of where there's large areas of deprivation. And then what we found is what I just described to you is the ability to zero in on our patients. Let me go back, sorry, one more thing. Zero in on the locations where there was high deprivation so that we could start framing up interventions to address patient needs. And Andrea is going to dive in to talk about that.
Good morning, good morning, good morning, good morning. Just to do a quick inventory, are any of you dialysis staff, dialysis patients? Okay, a couple transplant centers. All right, well, either way, I think you'll be able to take some of what we talk about here and be able to apply it to the populations in which you work with. And even though some of you may not work in the dialysis setting, I can almost guarantee that maybe all of you in this room work with individuals who are at risk for end-stage kidney failure. And that includes those who have diabetes and high blood pressure and other conditions as well, but certainly those two. So Amber talked to us about ADI, or Area Deprivation Index. And I just want to talk to you all a little bit about how we utilized ADI to really create intentional and meaningful interventions. And so we use that ADI. Amber talked about how we were able to flag different patients in different areas in our networks, networks 3, 4, and 5. What we then were able to do with using that data, we were able to identify where there was major need and then prioritize those dialysis facilities and our dialysis patients based on need. Of course, we work with all of our facilities and all of our patients, but it makes sense for us to prioritize those who are most impacted by inequitable access. And so that's what ADI allowed us to do. And so I'll just talk about maybe just 3 highlights of some of the interventions that we were able to develop as a result of using ADI. So the first was we decided to do on-site technical assistance. As CMS contractors, this is new for the dialysis setting where the network, which is who I represent, networks 3, 4, and 5, we're able to go on site now, and that makes a lot of sense. But given that we have hundreds and hundreds of dialysis centers in networks 3, 4, and 5, and I don't know if Amber mentioned that in Network 3, which includes Puerto Rico, New Jersey, it also includes the Virgin Islands. While I would love to travel to the Virgin Islands to do an on-site visit, really where we see a lot of the deprivation, but what I really like to call disinvestment, because a lot of that can be a policy choice, and that's how we end up with that level of deprivation. We see a lot of that in Puerto Rico. And so we have these on-site visits now, and the way that we are approaching this is in a 3-tiered approach, meaning those who are top tier, tier 1, these are our facilities who are serving patients who are the most disadvantaged, who stand to be most impacted by the lack of access to resources. And then, of course, if we go to tier 3, these are facilities that still have been identified as being socially disadvantaged or socioeconomically disadvantaged. However, we have prioritized them as not needing as many resources. So what that looks like for us is when we do these on-site visits for our tier 1 facilities, which require the most assistance, we're going to deploy to them 3 staff members from the network. Again, that's the network that I represent. So we will deploy more staff, and when we can, we will make sure that we have a patient subject matter expert to also join us on those site visits. We allow for these different dialysis centers to be able to choose kind of from a la carte menu of interventions, because we want for it to be individualized. And even if they choose to say, hey, I really want to focus on home dialysis, that's something that I want to focus on, everything is going to be through a lens of health equity. And even though we may have one facility in Puerto Rico, for example, who chooses to focus on kidney transplant, we may have another one in New Jersey who focuses on kidney transplant. The makeup of the patient population and the resources, not only the resources that are not available, but what is available in those communities is what we will leverage to make a tailored intervention for them. The second thing that we did, and I'm pretty sure that this is a little bit of a theme from what I've been hearing over the past couple of days, and that is identifying and partnering with other organizations. As a dialysis center, the 4 walls of that dialysis center, the patients don't live there. They have to walk out of that dialysis center. Prayerfully, they're walking out, but for some, you may be walking where there isn't very much walkability. The walkability score in your community may be very low, or you may not have transportation. Transportation inequity is very, very major for the dialysis population, and not having transportation does impact health outcomes very much. So we are really trying to partner with hyperlocal organizations to do what we can't. You all are already familiar with social determinants of health, and you can only imagine how that impacts individuals who have to show up to a dialysis center 3 days a week. We know the mental load that is, the emotional load for trying to show up and make yourselves available to a dialysis center. And so what that looks like for us in terms of partnering with community-based organizations is in Delaware, for example, it looks like us starting to foster a budding relationship and partnership with Literacy Delaware. We are currently working with them to build a curriculum so that we can offer on-site workshops to help our patients with health literacy. I'm gonna roll through these next slides a little bit, okay? And third, we are also promoting internal and external organizational health literacy. And I'm sure that others have mentioned health literacy over the past couple of days, right? I know that you all know what health literacy is. And so I won't read these definitions, but what I will say is for us at Quality Insights Networks 3, 4, and 5, we do not divorce personal or individual health literacy from organizational health literacy. They are one and the same, and we put the onus on us as an organization to make sure that we are delivering materials and we are engaging with our patients in such a way to where it is really fostering an equitable exchange of information, and that we are putting forth the effort to operate as a health literate healthcare organization and to help our providers, dialysis facilities, to operate as a health literate organization. These are the 17 variables that make up the ADI, in which Dr. Paulus talked to us about earlier. And these 17 variables fall under 4 domains: education, income and employment, housing, and household characteristics. We can't do much about that, right? We can't really help with the income and the employment part in terms of, being a dialysis organization or being a network who supports dialysis organizations. But what we can do is make sure that we make that connection for not only my colleagues at the network level, but for those dialysis centers. And so you see here that 38% of patients with less than a high school education, they recall health terms and information accurately only 38% of the time. Whereas patients who have a college degree, they recall health terms and information 65% of the time. So that is really just kind of building the case for why focus on health equity, why be a health literate organization. So again, what did that look like for us on the network level? Promoting health literacy. In doing so, we developed self-paced, evidence-based health literacy modules in English. We're rolling out one in Spanish because, again, we work with Puerto Rico, and this is for our staff. We want to ensure that we are providing information for all of our staff and having a train the trainer sort of an approach. We are encouraging a health equity champion. And so we go as far as putting out kind of a job description, what a health equity champion looks like at the facility level, and having that individual be the one to go through this module and be the person responsible for testing and implementing different interventions. And then we had a health literacy month, which is in October, health literacy month lunch and learn. And we focused on advancing health equity through health literacy, developing health literate materials, a how-to guide. If you all have not done something like that, I certainly suggest that you do the how-to guide. It is very hands-on, and you walk away knowing how to develop more health literate materials. And then applying learning style needs to improve the delivery of education and engagement. So these are just some of the ways in which we promote health literacy. And this is just the impact of our interventions. And please know that this is not something where there's a start and a stop. We are continuing to promote. We think of this as a phased rollout. So we're continuing with this work. I won't read this to you verbatim. Just know that we have had an impact. And I'll tell you, some of the greatest impact has been on the network level, really seeing my colleagues in different departments outside of the network really try to become more health literate in the different departments. Okay, so the more that we take the onus on us to improve organizational health literacy, the more that it impacts and benefits our patients. A look ahead, and I don't want to miss this, so I'm going to skip through all of this and just say that we're putting our money and our, we're putting our money where our mouth is, or whichever way the saying goes, right? Because now I'm rushing for time, but I won't forget this piece. Quality Insights, we are really, really trying to forge better partnerships, and that includes with all of you here. If you are doing work in provider care or grassroots or education and research, we want to work with you. We want to make sure that we are able to expand our reach and work with you all. And so right now, Quality Insights does have a grant. It is open until the end of June, so you have some time. So if you are doing work in any of the 3 priority areas that we have listed there, and you do work in the areas in which we are located, which is pretty much all of Mid-Atlantic, then, we want to work with you. So please go forth and, apply for this grant, and we hope to work with you. Also, these are other resources. A lot of these come with free CEs, so please feel free to take advantage of all of this. And we thank you. If you have questions for me or Dr. Paulus at the end of this, we will be around. Thank you.
It's still morning. Good morning, everyone. Our presentation is going to be just a little bit different. We are actually talking about our multifaceted program and our approach to working with a diverse Medicare Advantage population. However, our work is very much data-driven. So I'm Alena Baquet-Simpson. I am the executive medical director with Aetna CVS Health. I support our Medicare business. And I'm here with my partner, Shannon MacKenzie, and we're very happy to talk to you about our health equity work that supports our Medicare membership. In late 2019, our Medicare leadership made a decision that they wanted to evolve the work that was underway regarding health equity to go beyond language and translation. And instead, they wanted to fund activities that really would have an impact on members' lives. And so our current version of our community engagement and multicultural program was formed with the goal of creating a culture of health equity for our Medicare Advantage members and their communities, and to do so by implementing activities aimed at reducing and eliminating disparities. Initially, we focused on our Black and Hispanic membership and also on trying to improve outcomes around diabetes and hypertension. So as Shannon and I entered 2020 and the launch of this new evolved program, we were really excited. We had these grand plans of all the wonderful things we wanted to do in the community. And then, like everyone else, we ran into that brick wall of the pandemic. However, we were able to pivot and instead spend our time building a really strong foundation for our work that still supports us well today. We worked in lockstep with our data team, and they were able, with the use of race and ethnicity data from the CMS full enrollment file, they were able to identify for us disparities that we needed to focus on, geographic hotspots that we needed to target, and also members that we needed to work with. And then that information was validated by our care managers as they intervened with members. We also spent time building relationships with community-based and faith-based partners. In this way, this allowed us to engage the community in identifying what the needs were and also addressing solutions. We also were able to leverage those relationships and the credibility of those leaders in terms of enhancing engagement in our activities while we worked on building our own credibility in the community. And while we did this community work, we sought ways to add value to the existing activities that were already in place within the communities. We also spent a lot of time doing research and gathering information in the terms of focus groups. We were able to speak with our colleagues, with providers. Most importantly to me, we were able to interact with over 500 Medicare beneficiaries. We were able to take the direct voice of those beneficiaries and the other learnings from this focus group work and translate it into guiding principles that still drive our work today. We have 5 guiding principles which remain relevant. I'll just quickly read them in the interest of time or review them. One is alleviate barriers. We want to engage the community. We want to involve family. We want to address the whole person, and we want to use food as a way in. Our work has been designed around 3 pillars: member engagement, community engagement, and provider engagement. I'm going to talk about member engagement in a moment, but first let me give you a sense of what we were able to do around the other pillars. For community engagement, I've already mentioned that we sought ways to add additional value to activities that were already existing within the community. So this provided us with the opportunity to host many vaccination clinics, both for flu and for COVID. We have a televised healthy cooking show. We also were able to hold many educational sessions on various topics and added a healthy cooking demonstration to food pantry distribution, just to give you an example. The provider piece remains our toughest challenge. We initially started by interacting with our value-based providers. we looked for those who had a high density of, our membership and also a significant number of gaps to be addressed. We offered them training on implicit bias and also how to deliver culturally relevant care. The training came with CME, continuing medical education, and we also paid for their time to take the training. However, the traction with this was really far less than what we had hoped for. So we stepped back and engaged in additional focus group work, specifically trying to get at how we could enhance engagement of providers. And we're taking the learnings from that right now and using them to design phase 2 of our provider engagement. What I can share with you is that many providers are still struggling post-pandemic. They don't have the resources that they would like to be able to deliver the care that they would like to deliver for their patients. And they are asking us for help. So we are looking at incorporating that into phase 2. Getting back to our member engagement, it has 2 components: care management, which is a cornerstone, but also peer support. For our care management, the underlying objective is to facilitate the development of really deep, trusting relationships between members and their care managers. We've done several things to facilitate this. One is that we match members with care managers of similar backgrounds and language capabilities. We're trying very much to avoid the need to use the language line because that is not popular at all. We also have offered a lot of education. We use a variety of tools that have a multicultural focus, such as motivational interviewing and assessments. We use culturally relevant cookbooks as teaching tools. We've doubled down on nutrition and have referrals to dietitians available for members who need them. We also have our pharmacists completing comprehensive reviews. There's several learnings from that. The one that, and you can see them at the bottom of the slide, the one that I'll call out is that it's very important to make an upfront investment of time in building the relationship first before rushing on to the clinical. Take time, find the commonalities, and then move on to those important clinical issues that need to be addressed. We have a couple of different ways to monitor our progress. One is we use our key performance indicators where we look for improvement on STAR measures for those members who are engaged in our program. We're also looking for performance on different process measures like engagement and completion of those pharmacy reviews. However, the second way that we are able to monitor our progress is through studies. As we designed our program, we worked with our clinical analytics team and structured it in a way that allowed us to have randomized control studies. What you're seeing on the screen is the outcome of our first randomized control study. For all the members that we intervened with, we saw an increase in engagement compared to our core care management program. For members who were 65 and older, and also high risk, we saw a decrease in total medical cost driven by a reduction in inpatient admissions. Now, the success that we've seen with this gave us access to funding to allow us to expand the program. It's no longer a pilot. Right now, we're integrating it into our core care management program. And this is just how we're going to be approaching our members. It's also allowing us to expand peer support through the use of community health workers and community health educators. I'm going to transition to Shannon now, who's going to talk about our processes. Thank you.
Hello, everyone. I'm Shannon MacKenzie, and I'm a lead director at Aetna, a CVS health company. I'm really excited to be here today and being with so many like-minded individuals. Operationalizing health equity is no easy task. It has come with a lot of ups and downs, and the necessity to really find evidence-based tools to really incorporate into your organization so that you can have that consistency and be able to assess your readiness within the organization to provide comprehensive approaches to accelerate health equity. We searched a lot of different tools in our journey. We spent a lot of time in identifying what tools would help us to be able to assess our readiness and also be able to really look at from start to finish, how do we identify and then, actually impact the outcomes. And so we actually had, here, how about I switch this? Sorry. This one. Okay, thank you. So we had actually incorporated the CDC's community strategies for preventing chronic disease playbook. As Dr. Alena had mentioned, we have a couple different stakeholders that we've been really looking at integrating, and we found that this approach really did a great job in being able to tie those different organizations together around a common mission. If I could tell you guys one thing to take away from this, it's really do not reinvent the wheel. There are so many wonderful resources out there. You guys have heard even today about those wonderful tools, and it really helps then to also have that consistency with your partners and being able to understand that comprehensive approach and have that consistency to be able to implement it in different areas. Through the CDC roadmap, one of the first steps is around building organizational capacity. And I think that this is an area where if you're going through and moving through these steps, you may find that you have to come back to a step because you're not getting where you need to be. So if we're at a point where we're making the case for health equity, but the folks that we're making that case with haven't really embraced or understand the importance of this, then we need to go back to be able to highlight that individual and building that organizational capacity with really helping people to understand and acknowledge the presence of racism and discrimination in intentionally and unintentionally, and that it exists today. And it shows up in many ways. We have to acknowledge the fact that a lot of times innovation and improvements are not designed with a health equity lens. And because of that, there are many instances where you have unintended bias as consequences, and then that leads to disparate outcomes. And so we have been really focused on being able to integrate into our processes the standardization of how we look and evaluate health equity. And much of that is through our data analysis. We did a lot of work with the data and analysis team, and of course, all of these things are really continuing to evolve. It is incredibly important that we are, stay tight to the information that's coming down through the industry and being able to look at some of the, amazing changes that CMS is integrating into how they design programs and how they're looking at the foundational of health equity and how that can help to really bring people together, but make sure that everybody has a chance for wellness and health and mental health. That data analysis that we did was really to be able to have a roadmap to understand who, how, and why people were experiencing disparities. We chose to really narrow in and using actually the RAND report for disparities within MA. We were able to crosswalk different STARS measures to really look at our own population and see where we had disparate outcomes to be able to prioritize and really incorporate a semi-annual assessment using that data to make sure that we have an opportunity to really identify and then be able to make the case using that data to make the case for health equity. Because now we have that data to be able to show that if outcomes are differing by characteristics of the individuals, that's inequitable. And we need to dive into that. And we need to be able to look at the data and say, we can't unsee this, right? We can't just ignore this. We really need to lean into it and be able to understand how we can make that case for health equity, not only within our own organizations, but also looking to multi-sector partnerships to be able to have impact. We have a variety of organizations that we work with. They must come together to provide subject matter expertise, coordinate resources, and address social challenges with social solutions. As a healthcare agency, that is an area where we're really trying to expand and make sure that we understand that the power of being able to leverage these community experts who really understand the community needs and can be able to help to lead us in that development of interventions that are going to be effective. The last thing, and we're running tight on time here, so these will be available for a deeper dive, but I think the social ecological model of health is something that we have really incorporated and embraced. And it really makes sure that we have a comprehensive, multifaceted approach, because we can't just concentrate on the individuals. Our organization did invest in some leadership training through the Groundwater Institute. If you guys haven't had a chance to look into that, it is an amazing training, and really helps to understand that the issues are in the groundwater, and without fixing those issues in the groundwater, we're going to have partial solutions. And part of that is in the evaluation effort as well. What is important to me as a payer isn't what is important to another organization that might be doing social type of work. So you need to be able to have evaluation criteria that really hits in all those different areas. And I think a true testament to the work that Dr. Alena had discussed about the focus group work is when we took the actual findings and those foundational learnings and our foundations, we were able to overlay the social ecological model of health. And even though nobody said, hey, I think you really need to have an approach that incorporates a social ecological model of health from our the individuals that we were hearing from, the interventions that were suggested really fell into each of these categories just organically. And, that really, I think, underpins the power of hearing from those with lived experiences to be able to develop the programming, and using our framework where we're continuing to look and evaluate data and bring new areas of focus and new ways that we can partner with organizations. So I hope our journey has been a little bit helpful for you guys. And I think that I'll just leave you with the fact that, this work really requires that commitment, creativity, collaboration, and problem solving, but most of all, persistence. And we hope that you guys have a great time in your journey, and that we will hear from you guys about your experiences. Thank you.
So let's give it up for all of our amazing panelists who squeezed all this information in just 15 minutes. So we don't have time for Q&A, but I'm sure our panelists can stick around if y'all want to ask them any questions. They're here in the front row. And then I think we have an announcement from CMS about lunchtime, which I'm sure everyone also would love